Welcome. This is the New England Journal of Medicine. I'm Dr. Lisa Johnson. This week, June 27, 2024, we talk about treatments for eosinophilic esophagitis, reteplase versus alteplase for acute ischemic stroke, dupilumab for COPD with type 2 inflammation, and brigatinib in NF2-related schwannomatosis, a review article on amyloidosis, a case report of a man with recurrent fever and liver lesions, and perspectives on Alzheimer's disease, biomarkers, and mAbs, on climate litigation for protecting public health, on carbon footprint analyses in RCTs, and on the phantom of the organ. Dupilumab for eosinophilic esophagitis in patients 1 to 11 years of age, by Myrna Shahade, from the Icahn School of Medicine at Mount Sinai, New York, and co-authors. Eosinophilic esophagitis is a chronic, progressive esophageal disease that has a substantial effect on quality of life. Left untreated, esophageal fibrosis and remodeling can lead to strictures, food impaction, and associated complications. Eosinophilic esophagitis frequently occurs in children, in whom important complications of the disease are failure to thrive and reduced quality of life. Dupilumab is a human monoclonal antibody that blocks interleukin-4 and interleukin-13 pathways and has shown efficacy in 5 different atopic diseases marked by type 2 inflammation, including eosinophilic esophagitis in adults and adolescents. This trial evaluated dupilumab in children 1 to 11 years of age with active eosinophilic esophagitis that was refractory to proton pump inhibitor therapy. In Part A of the trial, in which participants were assigned to 16 weeks of a higher exposure or lower exposure to subcutaneous dupilumab or matching placebo, histologic remission occurred in 68% of patients in the higher exposure dupilumab group, in 58% of patients in the lower exposure group, and in 3% of patients in the placebo group. The higher exposure dupilumab regimen also led to improvements in measures of key secondary endpoints as compared with placebo. In Part A, the incidence of COVID-19, nausea, injection site pain, and headache was at least 10 percentage points higher among the patients who received dupilumab at either dose than among those who received placebo. Serious adverse events were reported in 3 patients who received dupilumab during Part A and in 6 patients overall during Part B, in which therapy was additionally assigned to those who had received placebo and continued for 36 weeks. Dupilumab resulted in histologic remission in a significantly higher percentage of children with eosinophilic esophagitis than placebo. Eosinophil depletion with benralizumab for eosinophilic esophagitis, by Mark Rothenberg, from the Cincinnati Children's Hospital Medical Center, Ohio, and co-authors. Benralizumab is an eosinophil depleting anti-interleukin-5 receptor alpha monoclonal antibody. This Phase 3 study evaluated the efficacy and safety of benralizumab in patients with eosinophilic esophagitis. 211 patients 12 to 65 years of age with symptomatic and histologically active eosinophilic esophagitis were randomly assigned to receive subcutaneous benralizumab or placebo every 4 weeks. At week 24, more patients had a histologic response defined as less than or equal to 6 eosinophils per high-power field with benralizumab than with placebo, 87.4% versus 6.5%. However, the change from baseline in the score on the dysphagia symptom questionnaire did not differ significantly between the 2 groups. There was no substantial between-group difference in the change from baseline in the eosinophilic esophagitis endoscopic reference score, which reflects endoscopic abnormalities. Adverse events were reported in 64.1% of the patients in the benralizumab group and in 61.7% of those in the placebo group. No patients discontinued the trial because of adverse events. In this trial, involving patients 12 to 65 years of age with eosinophilic esophagitis, a histologic response occurred in significantly more patients in the benralizumab group than in the placebo group. However, treatment with benralizumab did not result in fewer or less severe dysphagia symptoms than placebo. In an editorial, Benjamin Wright from the Mayo Clinic, Arizona, Scottsdale, writes that these trials provide critical insights into the pathogenesis of eosinophilic esophagitis. Eosinophils have been cast as destructive end-stage effector cells, but they also play beneficial roles in local immunity and remodeling or repair responses. In the trial by Rothenberg and co-authors, as anticipated, eosinophil depletion occurred rapidly within 4 weeks after the start of benralizumab treatment, and almost 90% of the patients had a histologic response after 24 weeks. Unfortunately, clinical symptoms of dysphagia did not differ substantially between the benralizumab and placebo groups at 24 or 52 weeks. Indeed, symptom scores appear to decrease more in the placebo group, and no pre-specified subgroups appeared to benefit symptomatically from the benralizumab treatment. The results reported by Shaheed and co-authors in the dupilumab trial confirm the importance of interleukin-13 and possibly interleukin-4 signaling in eosinophilic esophagitis. Nevertheless, several key questions remain. First, why do 1/3 of patients not have a response to treatment with dupilumab? And why are higher doses often needed? A longer duration of treatment does not increase the incidence of remission, which suggests that suppressing type 2 helper T cell, Th2, inflammation alone may be insufficient. Second, what are the long-term effects of Th2 blockade? Published trials are not designed to detect rare or long-term serious adverse events. Therefore, pediatric providers should exercise caution. Dupilumab use is associated with reports of conjunctivitis, facial dermatitis, arthropathy, psoriasis, and end-organ complications of hypereosinophilia. Third, what are the primary environmental insults that initiate Th2 responses? Allergic inflammation occurs after mucosal barrier dysfunction in eosinophilic esophagitis. Therefore, prevention and cure will require additional focus on exposures that disrupt the esophageal epithelium. Together, these trials provide exciting advances in our understanding of and treatment options for this increasingly common and perplexing disease. Reteplase versus alteplase for acute ischemic stroke by Shuya Li from the Beijing Qiantan Hospital, China, and co-authors. Reperfusion therapy is an evidence-based intervention for ischemic stroke. Alteplase is the standard agent used in early reperfusion therapy, but alternative thrombolytic agents are needed. Reteplase is a recombinant plasminogen activator that is administered with a double bolus approach. The boluses are separated by 30 minutes with a fixed dose regimen. In this study, 1,412 patients with ischemic stroke were randomly assigned within 4.5 hours after symptom onset to receive a double bolus of intravenous reteplase or a single dose of intravenous alteplase. The primary outcome of an excellent functional outcome occurred in 79.5% of the patients in the reteplase group and in 70.4% of those in the alteplase group. The primary safety outcome of symptomatic intracranial hemorrhage within 36 hours after disease onset was observed in 2.4% of patients in the reteplase group and in 2% of those in the alteplase group. The incidence of any intracranial hemorrhage at 90 days was higher with reteplase than with alteplase, 7.7% versus 4.9%, as was the incidence of adverse events, 91.6% versus 82.4%. Among patients with ischemic stroke within 4.5 hours after symptom onset, reteplase was more likely to result in an excellent functional outcome than alteplase. Dupilumab for COPD with blood eosinophil evidence of type 2 inflammation. By Surya Bhatt from the University of Alabama at Birmingham and co-authors. A subgroup of patients with COPD is characterized by evidence of local and systemic type 2 inflammation. Type 2 inflammation is regulated by type 2 helper T cells and innate lymphoid cells, and driven by inflammatory cytokines, including interleukin-4, interleukin-5, and interleukin-13. Dupilumab is a fully human monoclonal antibody that blocks the shared receptor component for interleukin-4 and interleukin-13, key and central drivers of type 2 inflammation. In this Phase 3 trial, 935 patients with COPD who had a blood eosinophil count of 300 cells per microliter or higher were randomly assigned to receive subcutaneous dupilumab or placebo every 2 weeks. The primary endpoint of the annualized rate of moderate or severe exacerbations was 0.86 with dupilumab and 1.3 with placebo. The rate ratio as compared with placebo was 0.66. The pre-bronchodilator FEV1 increased from baseline to week 12 with dupilumab, least squares mean change 139 milliliters, as compared with placebo, least squares mean change 57 milliliters, with a significant least squares mean difference at week 12 of 82 milliliters and at week 52 of 62 milliliters. No significant between-group difference was observed in the change in scores on the St. George's Respiratory Questionnaire from baseline to 52 weeks. The incidence of adverse events was similar in the two groups and consistent with the established profile of dupilumab. In patients with COPD and type 2 inflammation, as indicated by elevated blood eosinophil counts, dupilumab was associated with fewer exacerbations and better lung function than placebo. Brigatinib in NF2-related schwannomatosis with progressive tumors. By Scott Plotkin from Massachusetts General Hospital, Boston, and co-authors. NF2-related schwannomatosis is a tumor predisposition syndrome that is manifested by multiple vestibular schwannomas, non-vestibular schwannomas, meningiomas, and ependymomas. The condition is relentlessly progressive with no approved therapies. In this Phase 2 trial, 40 patients who were 12 years of age or older with NF2-related schwannomatosis and progressive tumors were treated with oral brigatinib at a dose of 180 milligrams daily. The primary outcome was radiographic response in target tumors. After a median follow-up of 10.4 months, the percentage of tumors with a radiographic response was 10% for target tumors and 23% for all tumors. Meningiomas and non-vestibular schwannomas had the greatest benefit. Annualized growth rates decreased for all tumor types during treatment. Hearing improvement occurred in 35% of eligible ears. Exploratory analyses suggested a decrease in self-reported pain severity during treatment, minus 0.013 units per month, on a scale from 0, no pain, to 3, severe pain. No grade 4 or 5 treatment-related adverse events were reported. Brigatinib treatment resulted in radiographic responses in multiple tumor types and clinical benefit in a heavily pretreated cohort of patients with NF2-related schwannomatosis. Systemic light chain amyloidosis. A review article by Vaishali Sanshurawala from Boston Medical Center. Immunoglobulin light chain AL amyloidosis is a rare disease that occurs when a plasma cell disorder produces monoclonal light chains, which misfold and are deposited as fibrils in organs or tissues. The signs and symptoms, treatment approach, and prognosis are highly variable and dictated by the nature of an individual patient's unique light chains. In the majority of cases, AL amyloidosis is characterized as a rapidly progressive disease with various clinical syndromes. Common nonspecific symptoms include fatigue and weight loss. However, organ-specific symptoms often lead to the diagnosis. Diagnostic delays occur because of low awareness among clinicians. One of the most important determinants of survival is the severity of cardiac involvement. However, the care of patients with systemic AL amyloidosis has undergone transformative changes, leading to marked steady progress in outcomes for patients over the past 4 decades. Substantial progress has been made through the implementation of treatments targeting the underlying plasma cell dyscrasia, mostly adapted from the treatment of myeloma. The arsenal of therapeutics for AL amyloidosis is rapidly expanding, offering a promising outlook for patients in 2024. While overall survival has improved considerably, many unmet needs persist. This review focuses on recent advances in our understanding of the pathogenesis and clinical features of amyloid fibrillogenesis, as well as risk stratification and therapeutic advances, and describes the unmet needs in AL amyloidosis. A 73-year-old man with recurrent fever and liver lesions, a case record of the Massachusetts General Hospital by Lakshmi Ganapathy and co-authors. A 73-year-old man was admitted to the hospital because of recurrent fever. 22 months earlier, 2 days of fever, cough, and fatigue developed. Empirical antibiotic agents were administered to treat pneumonia. During the subsequent month, the cough resolved, but fever recurred intermittently. CT of the chest, abdomen, and pelvis showed scattered solid pulmonary nodules, a few hepatic hemangiomas, and bilobar sub-centimeter hepatic hypodensities. 1 week later, MRI of the abdomen revealed that the hepatic lesions had increased in number and size, measuring up to 2.4 centimeters in diameter. Some lesions were only enhanced peripherally, a finding that suggested central necrosis. During the subsequent year and a half, the patient continued to have intermittent fever that had responded poorly to multiple courses of broad-spectrum antibiotics, as well as recurrent invasive bacterial infections that had required prolonged administration of antibiotics for resolution. The patient also had persistent lymphopenia, an elevated level of alkaline phosphatase, progressive hypodensities in the liver and spleen, and multiple pulmonary nodules. Splenomegaly had worsened over time, and portal hypertension had developed. Histopathological examination of bone marrow and liver tissue had revealed non-necrotizing granulomas. Common variable immunodeficiency, CVID, is the most prevalent symptomatic primary immunodeficiency in adults. Although CVID comprises a heterogeneous group of disorders, one key feature is the low levels of circulating immunoglobulins that are caused by defects in B-cell differentiation. Alzheimer's disease, biomarkers, and mAbs. What does primary care need? A perspective by Nathaniel Chin from the University of Wisconsin School of Medicine and Public Health, Madison, and Claire Erickson from the University of Pennsylvania Perelman School of Medicine, Philadelphia. A computer notification interrupts a memory specialist's end-of-day note writing. A patient's test result has just been posted. The patient, Ms. J, was recently diagnosed with mild cognitive impairment. Desperately hoping to be eligible for the new monoclonal antibody, mAb therapy for Alzheimer's disease, she sought a blood test for p-tau217. Her specialist, Dr. A, knows that Ms. J was notified of the posted result and sees she's already viewed it. Trying to avert alarm, he calls her to explain. When Dr. A asks Ms. J and her husband, "What questions do you have?" 45 minutes of rapid-fire questions ensue. Dr. A defines and differentiates mild cognitive impairment, dementia, and Alzheimer's disease to ground the discussion. Trying to focus on the blood test, Dr. A explains that the elevated amyloid result confirms the suspicion that Alzheimer's is the cause of Ms. J's symptoms. This scenario may soon be typical for clinical care of memory disorders. Discussions with patients and families have rarely been easy. The issues are nuanced, and families often inquire about experimental treatments they've heard about in the lay media. New mAb therapies and blood-based biomarkers now further complicate the conversation. Results of biomarker tests can be ambiguous, and yet these tools determine whether mAb therapies are even a possibility for a given patient. So more time is required for a clinician to explain results and discuss next steps. Indeed, diagnosing and discussing neurodegenerative diseases require training and time that few, if any, PCPs have. But many observers believe that diagnosing Alzheimer's disease will soon have to happen in primary care. Collective efforts by institutional, state, and federal stakeholders are needed to equip PCPs to provide memory care. If society wants earlier, more reliable diagnoses and access to advanced disease-modifying therapies, then a sincere investment in primary care is required. Alzheimer's biomarker testing and new therapies are poised to improve the diagnostic process and treatment, but without infrastructural change, the promise of these medical advances will fail to materialize. State and local climate litigation for protecting public health. A perspective by Avery Emery and Daniel Aaron from the University of Utah, Salt Lake City. Communities are struggling to shoulder the costs of establishing critical public health infrastructure to mitigate the physical and mental health effects of rising temperatures, poor air quality, and extreme weather events. Meanwhile, the U.S. Supreme Court has limited the ability of federal regulators to implement public health measures, including those aimed at addressing climate change. In the absence of a comprehensive national approach to confronting the climate crisis, various states and local governments have sought to use litigation to pass many of the costs of addressing the public health effects of climate change onto the oil companies that they allege have contributed to this crisis. Although the progress of these lawsuits has repeatedly stalled, a recent settlement on the eve of a trial in a related case brought by Cameron Parish, Louisiana, seeking as much as $7 billion in damages from 26 companies in the oil and natural gas industries, could be a bellwether for the efficacy of lawsuits against oil companies targeted at remediating the costs associated with climate change, including public health costs. Although the settlement amount in the Cameron case is unknown, the company's willingness to settle, despite dozens of cases pending, suggests that litigation could be a promising way for states and local governments to adapt to a changing climate. Physicians and public health practitioners can support these lawsuits by joining amicus briefs in pending cases, helping to develop evidence-based plans for the use of litigation proceeds, amplifying conversations about climate change and health, and encouraging their cities, counties, and states to join the wave of litigation. Carbon footprint analyses in RCTs toward sustainable clinical practice. A perspective by Lena Nordberg from the Diakonhjemmet Hospital, Oslo, and co-authors. Human-induced climate change and destruction of nature is a global health emergency. By 2030, an estimated 2 billion people will reside in areas considered to be poorly suited for sustaining human life. Immediate action to reduce greenhouse gas emissions in all sectors of society is paramount to support a livable future. Healthcare is a substantial contributor to the current environmental crisis. In 2021, the 26th United Nations Climate Change Conference Health Program urged the healthcare community to reduce emissions by building low-carbon, sustainable healthcare systems. But knowledge about the carbon footprints of existing healthcare interventions and how best to assess the environmental effects of new tests, treatments, and services in relation to their clinical benefits has been limited. As a result, it's been difficult to make evidence-based decisions focused on using clinically effective and climate-friendly interventions. These authors believe that an intervention's carbon footprint should be examined in parallel with its randomized trial evaluating clinical benefits and harms. The preferred method for quantification of the carbon footprint and other environmental effects of healthcare interventions is life cycle assessment, LCA. LCAs are systematic analyses that evaluate the environmental effects of products or processes involving various products, from raw materials extraction through production, use, and disposal or recycling. These authors recently started using carbon footprint as a secondary endpoint in RCTs, and found that most of the data needed to estimate it are also relevant for patient outcomes and health economic analysis, and are therefore already included in trial protocols. The Phantom of the Organ. A perspective by John Guzzi from Yale University School of Medicine, New Haven, Connecticut. "The lunatic is in my head," the patient rasps from his bed. Dr. Guzzi is sure he misheard the patient. The resident continues with his assessment. Postoperative day 2 after a deceased donor liver transplant. Overall doing well. I think we can take his central line out today. Dr. Guzzi and the resident shuffle out of the room and move on to the next patient. But after rounds, Dr. Guzzi returns to see this patient. Dr. Guzzi prepares to remove the line from the right side of the patient's neck. In a subdued but unmistakable melody, the patient mumbles, "The lunatic is in my head." "Pink Floyd?" Dr. Guzzi asks. "Hey, the one and only," the patient replies. Dr. Guzzi removes the line and presses a pack of gauze against his internal jugular vein, waiting for a clot to form. "I thought I heard you singing that earlier," Dr. Guzzi says. "I can't get it out of my head," the patient says. "Can I ask you something?" "Of course." "That lady in the corner of the room, she's not real, is she?" The patient points across the room. "She's over there by the window. Short, tan skin, middle-aged, brown hair, silent, but she seems kind." Whoever the woman is, the patient reports that she hasn't left the room since he woke up from his transplant surgery. "There's no one else here with us, but I believe you," Dr. Guzzi tries to comfort him. The resident's morning report on rounds is accurate. Post-operative day 2 and overall doing well. The patient is eating, drinking, walking, and now his lines are out. At first glance, this is the outcome that everyone hoped for going into the surgery. But despite this seemingly excellent recovery, nurses, physical therapists, and finally family members stop by Dr. Guzzi's workstation with the same question. "Did you know he's been seeing things?" "Not things," Dr. Guzzi says, "just one person." The patient knows his visitor is not physically there. He is alert, oriented, logical, and, up until this admission, did not believe in ghosts. But the patient cannot deny his perception. He sees somebody, whether she's real or not. In our images in clinical medicine, a 78-year-old man presented with a 5-day history of constipation and flank bulge. 8 days before presentation, he had received a diagnosis of herpes zoster of the left flank, and he had begun to take valacyclovir. On physical examination, scabbed herpes zoster lesions were seen along the T12 dermatome. There was also an outpouching of the left lower abdominal wall, without any underlying masses or fascial defects. CT of the abdomen was notable only for a protrusion of the left lower abdominal wall. Electromyography of the left rectus abdominis muscle showed a focal axonal neuropathy. A diagnosis of postherpetic abdominal pseudohernia was made. In patients with herpes zoster, motor complications may occur if the virus spreads from its typical location in the sensory dorsal root ganglia to the motor axons of the ventral roots. Abdominal pseudohernia is one such motor complication that results from paralysis of the abdominal wall muscles in the affected dermatome. Postherpetic visceral neuropathy has also been described and was thought to be the cause of this patient's constipation. Reassurance about the favorable prognosis of this condition was given. After 5 months, the patient's skin changes, constipation, and pseudohernia had abated. In another image, a 55-year-old man presented to the ophthalmology clinic with worsening vision and pain in his right eye after having been stung by a bee in that eye 2 days earlier. On the day of the bee sting, the stinger had been removed at a local emergency department. On physical examination at the current presentation, vision in the right eye was limited to counting fingers. A slit lamp examination with fluorescein dye showed conjunctival injection, inferior corneal edema, and an infiltrate at the nasal limbus with a piece of retained stinger. A hyphema, which was attributed to iris trauma from the buried stinger and bleeding iris vessels, was also observed. Jeweler's forceps were used to remove the stinger remnant. Ocular bee stings warrant referral to an ophthalmologist owing to the severe inflammation that may result from the injury, as well as the possibility of a retained stinger in the eye. Topical antibacterial and prednisolone eye drops were prescribed. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.